So welcome to this evening event that is run by EWMA and the Compression Therapy campaign, and also in collaboration with Legs Matter Coalition. And the colleagues that we have online today are members of the coalition. So welcome. Thank you very much for joining us this evening. We've got quite a lot of people online, so that's all very exciting. So the structure of the evening, we have an hour and a half. I know the football is on at 8, but if you can bear with us and stick with us until the end of the session, that would be fantastic. So this, I hope, will be a challenging evening and make people think and bring some insight into the world of compression, the power of compression. So a suggestion for you as listeners for this event is that you listen out for keywords, get a little notebook, jot down the words that inspire or challenge, put them in the chat, and make the most of this event. And as you're thinking and listening to these experienced speakers, identify any challenges that you think you will have for yourself or for the system, in which case, in which you're involved. Can they take on the thoughts and ideas that the speakers will present? So please make the most of the Q&A, and we will definitely leave time for talking at the end. So we have 5 sessions, and I'm Alison Hopkins. I'm Chief Executive of Accelerate, excuse me, but I have a background of tissue viability and community nursing. And I'm chairing this session today. So each of the speakers will just introduce themselves as they come on board, and we'll just start the session now. So it's being recorded, and it can be watched later on through European Wound Management Association, as well as through Tissue Viability and the Legs Matter Coalition. So if you're not familiar with Zoom, lots of us are more familiar with Teams now. There's 2 functions at the bottom, chat and also Q&A. Please make the most of that and challenge us as to what we're hearing, what you may be hearing. These are the collaborating organisations, and several of us are examples of that today. And the Compression Therapy Project, sponsored by the European Wound Management Association, is supported by these companies, and the Legs Matter is also supported by these key sponsors. So thank you very much for all your support. Oops. So why this campaign? Why are we gathered this evening? And hopefully, why are you interested in this gathering this evening? So we're very clear that the UK, because this is the audience we're speaking to, there may actually be people from around Europe or further afield, but this comes from a UK base and our understanding about what's possible within the UK. But the UK and across Europe does not use compression therapy enough. And the lack of use creates harm for our patients and also harm for our staff. It creates an awful lot of work where that work wasn't needed. The Legs Matter Coalition has been looking at how we can raise awareness for patients and staff about the issues around legs. And we started, I think, 2017. Leanne or Sarah will correct me on that if that's wrong. And it was the forerunner, I think, actually, of the National Wound Care Strategy that we were able to encourage the start of doing something different, creating a drive for change. And the National Wound Care Strategy is a very important arm of this work in the UK. And we in the UK and nurses have their role in choosing whether compression can be put on a leg, on a person or not. And so we have an opportunity to look at early intervention for lower leg wounds. And we will put the links within the chat. But basically, the legs you see in front of you, one is dripping, the one in the middle, and one is cellulitic, both of which can be avoided through the power of compression. So we have a campaign video that Niles is going to share from EWMA. And this was developed, it's a 2.5-minute video. And Niles, I should have checked, do I need to stop sharing my screen for you to do that?
Yeah, I'll share now.
Thank you. And this was developed by the European panel, and this is the English-speaking version.
Compression therapy has the power to heal wounds. It is a cornerstone in the treatment of most ulcers on the lower legs. This is supported by substantial evidence and guidelines. Without compression therapy, many wounds will not heal, and patients may suffer from non-healing wounds for years. With compression therapy, you may control pressure to increase blood flow in your legs, improve blood flow to the heart, support your veins, and decrease swelling. Most individuals with wounds on the lower legs need compression therapy to support wound healing, but too many are never offered the treatment. Therefore, we need you to help keep patients safe by ensuring patients' access to compression therapy. Compression therapy is multifunctional. It reduces venous hypertension. It has anti-inflammatory properties, reduces pain and exudation, reduces skin problems and oedema, and reduces healing time and reoccurrence. A light compression therapy is suitable for all lower limb wounds. Evidence shows that most patients appreciate compression therapy and follow the instructions when provided by their healthcare professional. It can easily be adapted to the needs of the patient and should be applied early for the best outcome and good patient acceptance. Compression therapy is simple to use, but makes a big difference for the patient. Support a new culture. Use compression in your wound management, so your co-workers will start using it too, and patients will benefit. We need you to help individuals with leg ulcers receive the compression therapy they need. Help them cope with this important therapy through good discussions about exactly what is difficult and what adjustments can be made. Educate yourself and your patients in the use and importance of compression therapy. Many online resources are available. Find out more.
Thank you very much, Niles. I will now share my screen. Lovely. Thank you very much. So this was developed, it's a simple tool. For those of you that know compression well, you know it's a complex treatment, but we're trying to take away the fear of compression and to use it more boldly because of the power it has as a tool to aid healing. So why is compression therapy important? Well, some of this is going to sound very repetitive, but it has the power to heal. And that's it in a nutshell. It does. It's a powerful tool in your hands. And without compression, we have many people, and you will know them personally, of people that don't heal. They have leg ulcers that could have healed. They have leg ulcers for 5 years and where they've never seen compression. This is not right. And we think it needs to be challenged as harm. There is an awful lot of evidence for compression therapy. We don't need any more. And this seminar will talk about the benefits of compression therapy. But again, these things are really, really important. So we're just going to re-emphasize all of these aspects of compression therapy. We know that it's compression that heals wounds, not the dressing. We know that compression provides a therapeutic intervention, and it does many things in that intervention, and we'll be talking about that. What we need to do is think of compression as a dose of therapy. And when we use it, it creates less work for the nursing staff, reduces infection, reduces admission, and aids healing. And in the UK, we are really privileged to be able to make decisions about people's care. And we're able to bring in compression really early. And that's where the National Wound Care Strategy comes in. And the end of the session will also look at compression products and how we can make that personal. Oops, sorry. So we have a poll I realised we've missed one of them, haven't we, Niles? I walked straight past it, which was where do people, what's their role in nursing? So I apologise for that, but we'll skip on to this one, and maybe we can have that at the end in the chat, because it'd be really interesting to know where people come from. So this one was the reasons for non-use. That's great, I can see that. So why is it that we don't use compression? So please, can you choose, all the learners here, just choose one thing you think of all of these 5 issues, this is the main one. And we'll give you just a sort of half a minute to complete that at the most. Doesn't need much, but why is it? When you look at this, is it lack of training, lack of confidence, patient compliance issues, just wasn't prescribed, or you think actually it's not suitable for a large number of your patients? So what's the most common reason? So we'll just give that a few seconds. And it's always interesting because this, what we believe, feeds into our work, into the culture of what we're doing and what we're seeing and what we're feeling. How many have you got, Niles?
I've got 195 answers.
Okay, well, let's have a look at what's the most common. Let's see what the results are here.
Yeah, I'll end the poll now, and it should be.
Lack of training, 44%. Lack of confidence, 24%. Patient compliance, 20%. Not prescribed and not suitable. So the most common reason that you believe is a lack of training. May well be right. We find a lack of confidence is a big thing as well, because of the fear factor around compression. People are terrified of doing the wrong thing, so they don't do anything. So thank you, Niles. You can close that one. So when this is some data that I'm bringing from some work we did with EWMA around prevalence audits. And when you do a prevalence audit in a community trust, what you find is around 25% of people of a wound prevalence audit will have a leg ulcer. What we found by digging deeper into this was actually it was far more common than 25%, and it was upwards towards 50%, because patients are hidden within 2 groups. And I wonder in the chat which you would say was the 2 groups, but it's surgical and trauma. Surgical and trauma. They are still wounds on the lower legs. They may have a different cause, they may not have been spontaneous, but they are lower leg wounds that actually need compression. And then we looked at access to compression, and what we found, of course, you would expect this, is that most people in leg ulcer clinics had high access to compression. There was 95% plus people in compression leg ulcer clinics. But what we found in this audit of around about 6 trusts was that as you got older, your access reduced significantly. And that's something we have to pay attention to and wonder why that is to that extent. We also found a lower use in some trusts of compression for lymphoria, and that's another term would be wet legs or red legs, and all of them need compression. So you've just got to wonder how for one trust it was 10%. What we find is that if the patient is known by a TVN, then their access to compression increases. And where there was no use of compression, their workload increased significantly by 45%. Now, you may not believe that, but that's the data coming through. And so we know that compression is a postcode lottery for many people, and this needs to be challenged when it is evidence-based treatment. We also know through the Legs Matter Coalition that we have stories coming through of real lives where, to be honest, their life story, their trajectory to chronicity could have been avoided with good, positive use of compression therapy. And that's what this is about. Early intervention is about nipping things in the bud. Don't wait until things are disaster before going, oh, they need compression. We've got to start early. So that's what this workshop is about. Oops, sorry. So one of the other myths, and I'm going to hand over to Joanne now, is that those with diabetes should, compression is like dangerous for this group. So Joanne, what is your take on this?
Hi, thanks, Alison. Yeah, so the foot itself is a very complicated structure. So we've got lots of skeletal anatomy, small bones, bony prominences. There's not an awful lot of soft tissue and fat distribution sometimes. So typically, there's always been a little bit of a fear around using compression. However, there is actually evidence now to suggest that as long as the patient doesn't have severe chronic acute comorbidities, such as renal disease, vascular disease, severe neuropathy, that actually you can use compression and that it will be beneficial to the healing of ulcers. I mean, it's interesting with the foot. Typically, podiatrists haven't used compression. It's a new theme for us to be getting involved with. And that's really coming around through the MDT working and the collaboration that we see, which is why it's so great that podiatry is involved within Legs Matter and why you've asked us to come and chat today. So it's really useful. So it would actually be of benefit to use compression as long as we consider renal disease, any infection, ischemia and neuropathy. But of course, when we think about a patient with diabetes, we do know that they have to be referred very quickly within 24 hours to an MDT. So you'd be then thinking of a personalised care plan, and these assessments would be going on anyway with a foot ulcer, not necessarily with a leg ulcer so quickly, but a foot ulcer. So it is important to make that differentiation between getting them into fast-tracked into that MDT, where they can get the proper assessments and a personalised care plan with a working diagnosis, and then of course using compression therapy. I mean, in my role as a diabetes specialist podiatrist previously, we have used compression in patients that have had not acute ischemia, but with some level of ischemia. And that was because the vascular surgeons had said, yes, let's do it. So you can always ask for support as well. Bring that MDT voice together. So in answer to your question, Alison, yes, it would be something that we would be advising to be using with caution and an MDT opinion. But yes, it can benefit. And there is evidence there that we've highlighted on the screen. That's some approach that's been using an edema with a diabetic foot. Because of course we have to think with the feet as well. Swollen limbs can affect gait and mobility. So of course, if the patient isn't able to mobilize, we're going to get more of a chronic dependent edema. So we have to be thinking about that rehabilitation phases as well. But just bear in mind there's other comorbidities in the pathophysiology. So I think that's probably answered your question. So shall I hand over to...
Yeah, thank you very much, Joanne. And I think what's important here is this little diagram in the middle that you brought in from the national strategy, because it differentiates between a leg ulcer above the dotted line and a foot ulcer below. And this is, again, a great move forward for us to differentiate between the two pathways. And so if they have diabetes with an ulcer above the line, this is where early intervention is absolutely suitable for lower leg wounds.
Just actually as a side, Alison, just to go on from that, just really briefly, I mean, as podiatrists, we also have to remember if there is dependent edema and we're dealing with just with a foot ulcer, that if we're using a bandage around the ankle, that can also create a kind of tourniquet effect. So we do need to be thinking of taking things above the ankle in our treatment. So again, just a thought there.
We've got a lot to learn. Thank you very much, Joanne, for joining the webinar as well from Legs Matter. So this is over to Sarah Gardner now. Sarah, if you can just introduce yourself, and Sarah's going to be talking about what compression does, and I'm going to stop sharing. Thank you very much.
Thanks, Alison. And I'm just going to share my screen now. Okay, can you see that?
Yes.
Yeah, you can see that. Brilliant. Thank you. Hi, I'm Sarah Gardner and I'm current chair of the Legs Matter campaign. I'm also an independent tissue viability consultant. Previous to that, I did lead tissue and leg ulceration has always been a particular interest of mine. So I'm delighted to be part of this important webinar tonight. So I'm going to talk about what exactly does compression do. Well, it's already been said, but you know, this has the power to heal wounds. It is repetition. We are duplicating that message, but it's really important that we continue to say that the same thing, really. It is a cornerstone in the treatment of most ulcers on the lower leg. As it said in the video that you saw, most patients with venous leg ulceration are happy to have compression therapy. But I think, you know, we do have a responsibility as clinicians to have that knowledge ourselves and that confidence to relay to the patient, explaining about their underlying disease and the benefits of compression. If we're hesitant ourselves, it's going to make patients nervous. So it's important that we have the confidence to be able to explain all of the benefits of compression therapy, what it actually does, and the positive outcomes that can be achieved by wearing compression therapy. So I have a polling question as well. Okay, so my question is, compression therapy is multifunctional. How many main functions do you think it has? If you could pick one of those, please. Just going to give you a few seconds. Okay, have we had many responses to that? Do you want to launch the results, Niles, please? Oh, okay, so most of you have gone for between 4 and 6 main functions. That's great. Thank you very much, Niles. That can be closed. Okay, so in fact, the amount I've got listed here I'm going to go through with you today is actually 10. There's possibly some functions here that maybe you haven't thought of. So I'm just going to go through those with you. So firstly, it reduces venous hypertension. And this is the crux of what's going on with faulty valves within the veins. And it is causing all this tissue flooding and hypertension within the veins, and therefore you get this congestion causing all of these problems. So we can't actually heal the valves, the faulty valves, so the compression won't do that, but what the compression is doing is assisting the function and therefore restoring the competence of the valves. And then if you think about the veins themselves, you've got this reflux going on. So where you've got the faulty valves, you get reflux of blood. And so what the compression is doing is suppressing or reducing that amount of reflux that's going on in the superficial and the deep veins. It helps with the velocity, so the sort of power and the force of blood returning back up the body. It's assisting that, and it's doing that because really it's adding a casing to the leg, which helps support the calf pump, and therefore any movement, whether that's mobility or just exercise of the foot, that's helping the blood return properly back up the system. So it's helping that capacity of the calf pump. One of the second function is about reducing inflammation. So anybody who's got venous disease or a venous ulcer, there'll be an inflammatory response going on, that could be due to the amount of edema that the patient's got in the limb, but the limb will be inflammatory, and that inflammatory status will prevent the wound from healing properly. So what compression does is it helps. It's an anti-inflammatory, because when you've got an inflammatory limb, you'll have these elevated inflammatory cytokines that are present. So what the compression does is it helps to reduce those inflammatory cytokines and actually increases the anti-inflammatory cytokines. So you know, that will help reduce the inflammation, but also has an impact on infection as well. And we'll go on to infections shortly. We know when people have venous disease, and particularly when people have got leg ulceration, there's often the presence of oedema. And so what compression will be doing is it will help reduce that level of oedema by squeezing the leg, and it's basically helping restore the function of that sort of tissue flooding. So where you've got tissue flooding, you need to be assisting the reabsorption of that fluid and assisting the lymphatic system as well, and that's what the compression does. So it helps reabsorption back into the vascular and the lymphatic systems. We know that in venous leg ulceration, particularly if there's a lot of oedema, there's high levels of exudate. And this is one of the major impacts on somebody's quality of life. If you think about living with a limb or a wound that is leaking to this extent, seepage through dressings and bandages, you know, we only have to sort of think about living with that for an hour in our life, but these patients are often living weeks, months, and sometimes years with this problem. So what compression does is it helps that decongestion of the limb. So it's shifting oedema and it's assisting that reabsorption of fluid back into the venous and the lymphatic systems. But that anti-inflammatory impact as well will also have an impact on exudate too. Pain is a particular problem. It's probably one of, you know, they're at the top of what patients are experiencing when they have leg ulceration. So what compression does is it's multifaceted really, because often pain can be associated with that congested limb, the amount of oedema, as well as the ulcer being very inflammatory. So again, it's this anti-inflammatory effect, which is helping reduce pain, but also as it decongests the limb, shifts the oedema, people are more comfortable. I know that you've probably experienced where patients think you're quite mad when you're suggesting putting firm compression onto a limb when they have this discomfort. But again, it's having the confidence to explain how the compression works, because once it's on, very quickly the limb decongests and the pain level comes down. It reduces infection, because infection can be a reason for pain as well. But also you'll get wound-related problems that are increasing pain, such as inflammation or infection. So again, the compression will resolve that. And by improving the venous return, again, it helps with pain reduction. Infection we've already touched on, but this anti-inflammatory impact of compression, so it's helping increase the anti-inflammatory cytokines, which will then reduce the risk of infection developing. So managing oedema, reducing exudate, and the compression stimulating these anti-inflammatory cytokines will reduce the risk of getting infection in that limb. You know, the reduction of exudate, we know that exudate is responsible for wound infection. So if you can manage that by having compression on, that will reduce the risk. And improving venous return and the microcirculation as well. You know, reduction in oedema, and all of these together will help promote better wound healing, because it provides a better environment for wound healing. Think about the skin. So tissue flooding and the impact of venous disease, it results in a number of skin related problems, doesn't it? From the oedema, for varicose eczema, for example, people who get the lipodermatosclerosis, that hardening, and that it's very painful and tight. So what compression does is it helps restore the health of the skin by supporting reduction of those underlying symptoms. So for example, that image at the bottom, which is quite extensive venous dermatitis, due to the tissue flooding going on within the system, the compression will start to resolve that. So even though you need to be thinking about skin care, compression in addition will quickly resolve some of these problems because of its anti-inflammatory nature. I think it was mentioned earlier that compression, you know, if you look at the evidence out there, we know that people in compression, their time to heal will quicken. And is such an important communication to your patients as to, you know, why the importance of compression. It will speed up healing because of all of the things I've said previously, the reversing the venous hypertension, anti-inflammatory, reducing exudate, etc., and improving that venous return and microcirculation. But ultimately, you know, compression, and if we continue with compression after healing, it will reduce the risk of recurrence, because what we're doing is sustaining that improved venous return and venous function. It supports the limb in terms of preventing the recurrence of oedema, and it sustains that anti-inflammatory sort of status. So it will reduce any complications of infection. And I know sometimes patients think that when they're healed, they're cured, but it's about the messages that we give that we talk about sometimes being in remission, don't we? Because we haven't healed the problem, we haven't healed the valves and the need for some sustained compression as we move forward. But ultimately, compression will improve a person's level of mobility and therefore their quality of life. You know, that reduction of an oedema and that improved limb function, whether that be somebody walking or whether just they can activate their calf pump, for example, sitting in a chair. That reduction of pain will impact massively on improving somebody's quality of life. And I think, you know, that is one of the main things we should be aiming for. So how do you use compression therapy? Well, the immediate and necessary care supports the application of mild or light compression, which is up to 20 millimeters of mercury at the ankle. And then obviously once we've assessed our patients and we've ruled out arterial disease, we should be stepping up with confidence to strong compression, which is a minimum of 40 millimeters of mercury. And that should be immediately after our holistic lower limb assessment. So I would like to now pass over to Dr. Leanne Atkin, who's going to be talking to you about the importance of creating a compression dose. Over to you, Leanne. I'll stop sharing.
Good evening, everybody. Lovely to see you. I'm just going to start to share my screen, and hopefully you can see that now. So my name's Leanne Atkin. I'm a doctor, but a doctor by PhD. My background is in nursing, and I'm a vascular nurse consultant at Mid-Yorks NHS Trust. And I am still down and dirty in Leg Ulcer Clinic 3 days a week. So you've heard so far about the importance of compression, the power of compression and what it can do. So I just want to talk to you really about compression dosing. So my poll question to you is, 40 milligrams of mercury compression is the optimum level of compression for healing a venous leg ulcer. Is that statement true or false? So I'd like you just to consider those words, and I'd like you to think about whether you think that statement is true or false. And we'll just give you a few minutes to answer that. And as you're answering, I just want to really reinforce, and like Sarah said, some of what we're saying is repetitive, and the need for that repetition is actually so you get the bigger picture. When we talk about compression therapy, I want you to look at a venous leg ulcer in a different way. I don't want you to look simply at the wound. I want you to be thinking about the roots. I want you to see venous leg ulcers as weeds. If you had a weed in your grass, like a dandelion, you wouldn't be chopping the dandelion's head off. You'd actually be targeting the roots. And that's what we need to do with venous leg ulceration, because it's not the wound that is the issue. It's that venous hypertension. It's that visible varicosity that you can see on this patient. So let's see what your answer is in terms of that poll question. Do you think 40 milligrams of mercury is the optimum? And it's fantastic to see that actually we've got a nearly 50-50 split. 62% of you thinks that 40 milligrams of mercury is the optimum level of compression, but 38% of you said that's false. It may not be the optimum level of compression. So by the end of this, we will answer which one of those is true. So let's just go back a stage, because Sarah's already touched on the disease mechanism. When I talk about the roots, what am I actually talking about? And you've got to remember this cycle of this venous insufficiency, that incompetence of those valves. So therefore the blood cannot move in a segmented section up that superficial venous system across those perforators into that deep venous system. When that happens, we get higher pressure within those veins that shouldn't be there. That spreads those valves across to make them even worse at being competent or touching. That starts to change the actual cellular structure of the vein wall. It makes the movement of cells from the blood fluid into the surrounding tissue much more easier, because the wall of the vein starts to become more permeable. When that starts to become more permeable, the vein can actually start to weaken and relax. So you get further dilatation of the vein. The bigger the dilatation, the worse the valves work. The bigger the hypertension, the more the walls change, and we go round in this vicious circle. And all of this results in what we see as chronic venous hypertension. Now, I like to think of this in the most simplest of things. When you get high pressure within those veins, the blood products, the parts of the blood, start to leak out into that surrounding tissue. There's three major components of blood. Number one is plasma or platelets. Let's call that fluid. That starts to leak out into surrounding tissue, so you get edema. The next component of blood is red blood cells. So when that starts to leak out, the red blood cells slowly dissolve, but they leave behind the hemoglobin, the iron content. And that's why you get that brown skin staining, that hemosiderin staining. It's from that leakage of that red blood cell into that interstitial space. And finally, the third component of blood is white blood cells. And you know that white blood cells is part of your inflammatory and infective response. So what happens is when the white blood cells leak into that surrounding tissue, they send off a chronic cascade of inflammation. It's like somebody constantly itching the skin, if you like, from the inside. It causes that chronic inflammation. It causes that erythema that we see. It causes eventually that skin breakdown. And that's truly the cause of venous leg ulcer. So if you think and you remind yourself that when we're talking about venous disease, the arteries carry the blood down, the veins carry the blood back, but it's not a closed system per se. It's actually the cascade from one system to the other happens through that capillary network. So if you've got engorgement within that capillary network, you're pushing those three blood products into that surrounding skin. And if you can see on that bottom picture, that green lacing, if you like, they're the lymphatics. So you can see how quickly the lymphatics can become engorged, and therefore they also become failing. So we have problems of the movement of the fluid from that lower limb back into that circulatory volume. So when we're talking about the levels of compression, the dose of compression that a patient needs, we need to be mindful that the level of compression we're going to apply, that we're going to suggest, actually impacts on that capillary bed. That's where we need to be targeting. We need to be thinking about that in our mind's eye. And it's really interesting that across the UK, we think that the optimum level of compression should be 40 milligrams of mercury. But I hate to say it, if that was your poll answer, you're slightly wrong. It's actually, that statement is false. And it's false because the optimum level of compression is an individualized assessment of requirement. And it's really interesting that across the UK, we talk about strong compression being 40, light or moderate compression being anything below 20. Look at what these levels are, and this is from the World Union of Wound Healing Association, and these are their levels of compression. So they talk about mild compression being up to 20 millimeters of mercury. They talk about moderate being 20 to 40. Remember, 40 can be our optimum. They talk about strong compression being a minimum of 40 up to 60. And they even talk about very strong compression. In other words, greater than 60 millimeters. There are some patients that require greater than 60 millimeters of mercury compression to target that capillary bed. So there are many things that actually influence the level of compression. In other words, is the bandage that we're going to apply, is that going to be mild compression, moderate compression, or strong compression? And it's not simply what box you choose and what does it say it does on the box. The level of compression is really impacted by the limb shape and the limb size. It also is really impacted by the level of calf muscle activity. So in other words, once you put that bounding material on that leg and you get that rebound of that calf muscle activity, how much does that impact on that venous disease? How much does it push that blood from those superficial venous system through the perforators into that deep system? It is very much impacted on the type of compression bandage, compression hosiery, compression wrap system you use, the characteristics of that specific fabric. What type of material is used? How stiff is that material? The design of that bandage, is it an elastic system, an inelastic system, or a combination system? It's also very much impacted on the bandage width and the degree of overlap. And this is where Laplace's law comes in, that many of you will have heard about. That's impacted by the number of components you use. Is that a multi-layer system using 2 bandages, 3 bandages, or 4 bandages, or even more? But it's really impacted on the application tension and the application technique. So you need to be mindful of all of these things when thinking about what dose of compression does my patient need to be optimum. Because if you look at these 2 pictures, you can see that actually, think about in your mind's eye that capillary bed that I've showed you behind these patients. If you look at that patient on the far left, you can see that hemosiderin staining, that movement of those red blood cells into that superficial tissue, the breakdown of the hemosiderin and the deposits of that iron. To actually impact on those valves and that venous hypertension for that patient, you're probably only going to need 40 millimeters of mercury pressure. But think about that second patient. You can see there are chronic signs of erythema around both of those gaiter regions. That's that white blood cells being deposited into that subcutaneous space, constantly activating. How big is that leg? How fibrotic or soft is that tissue? You're going to need a very different type of compression system and probably a very different dose of compression to be able to impact on that underlying disease mechanism. So we talk about compression doses across, let's call it early intervention, treatment and prevention. Many of you will have heard of the National Wound Care Strategy Programme. It is a programme just for England, but I urge you all that wherever you are across the globe or any nations to have a look at this. It's great free to access information. And the National Wound Care Strategy Programme has done really one amazing thing, if you ask me, and this has been backed up by EWMA, who also support this way forward. They ask that every patient is assessed for the red flags. In other words, the red flags where compression is not needed, something else is needed. It's not the fact that really compression may be dangerous in these patients. It's actually these patients need a different management plan. So the red flags include acute infection on the leg or the foot, signs of sepsis, any form of acute or chronic limb-threatening ischemia or critical limb ischemia, suspected DVT or suspected skin cancer. You need to screen every patient that you're seeing with a lower limb wound for those red flags and escalate appropriately. In the absence of those red flags, the National Wound Care Strategy Programme and EWMA are saying you can apply mild graduated compression up to 20 millimetres of mercury pressure without any formal vascular assessment. No foot pulse palpation, no ABPI, no toe pressure, no Doppler auscultation, simply elimination of red flags, and you are safe to apply up to 20 milligrams of mercury pressure. And this is really important, why you need to understand the doses of compression that your systems that you're using in day-to-day practice deliver, because we want you to give up to, but no more than 20 millimeters of mercury pressure without a formal holistic assessment. To use a stronger level of compression, the level of compression actually that's therapeutic for a venous leg ulcer, we need that to be embraced within a holistic assessment. And when I talk about holistic assessments, I like to break it down to holistic assessment of the patient, the limb, and the wound. And I think these three things help to really think about how you dose your compression. So in other words, the patient, how big are they in terms of their BMI? How tall are they? Have they had a previous DVT, therefore they're more likely to have deep venous incompetence rather than superficial incompetence? The extent of the varicosities, what can you see? How many of those varicose veins and how high do they go? If the patient's got diabetes, we need to be slightly more cautious, but compression is certainly not contraindicated. We need to be wary if the patient's had any arterial intervention in the past, because real strong compression may not be suitable for this patient. We obviously need to assess the patient's pain and the level of mobility of what type of compression is going to be the best. Once we've assessed the patient, we need to be thinking about the limb. What is the extent of the edema? Where is the edema? What is the extent of the tissue inflammation? The more edema, the more tissue inflammation, the stronger the level of compression needed. What is the condition of that tissue? Is that tissue soft and doughy? Can you move that edema, or is it fibrotic and thickened? Therefore, a stronger type of compression would be needed. If they've had a venous leg ulcer in the past and they've been in some recurrence level of compression, what level was that? Because if a patient with a venous leg ulcer has recurred in a certain level of compression, it's telling you you need a greater dose of compression to keep that edema and that venous hypertension at bay. And obviously, when we're talking about the limb assessment, we need to assess the arterial supply in terms of the using an ankle brachial pressure index or a toe brachial indices. But then we need to think about the wound. We need to think about the location. If a wound is sat behind the malleolus, a retromalleolus ulcer, often you need stronger compression or targeted compression on that area. What are the levels of exudate? Alison Hopkins told me once that if it's leaking, it needs more. And I 100% believe that. If you've got a patient already stabilised in compression therapy with high volumes of exudate, it's telling you you need a stronger dose of compression. What's that tissue type on that wound bed? What is the condition of the wound edges? Are they cliff-like? They're not healing. Are they beach-like? You're going in the right direction. And you need to assess the wound in terms of the overall etiology. Is this a venous ulcer? What is the actual diagnosis? When you put the patient, the limb and the wound assessment together, this is where you can individualize the dose of compression that you need to ensure your interventions are therapeutic. To be thinking about, where do I need to use mild, moderate, strong, or very strong compression? We need to be thinking about, some people need a higher dose of compression than the optimum 40. Because EWMA truly believes that compression therapy should be adjusted in doses varying from this mild to strong, according to that individual patient need. So how do you know the compression that you're using? How do you know the dose is optimal at this moment in time? Well, it's about your outputs. It's about, have you got a limb that's actually showing limb volume reduction? Wound healing in venous leg ulcers doesn't come first. That's not the sign of the right dose of compression. The first thing that happens is if you've got edema, the edema starts to reduce. If the edema is reducing, you've got the right dose of compression, the wound will start to get better. Have you got a wound that looked like it had big steep cliff edges and that wound is granulating up and the levels have become more beach-like? You've got the right dose of compression. That really inflamed area of erythema that you had around that gaiter region, is it becoming paler? Is it becoming less painful? Is it becoming less inflamed? If so, you've got the right level of compression. But we have to remember what are the signs and symptoms of suboptimal compression. The one thing of the suboptimal compression to me is the increased uncontrolled edema. This patient's leg requires stronger compression to be able to control that underlying venous inflammation. All we've done by having that uncontrolled exudate is cause that maceration, that extending of that wound size, that elongated time to healing, that increased patient suffering, that increased cost, the increased service demand requiring that regular out of hours dressing service. There is an increased risk of infection and an increased risk of hospitalisation. And I challenge you all that if you've got a patient with a venous leg ulcer and a wound that looks like that, we need to be thinking that actually, are we delivering direct patient harm? Because that is a suboptimal level of compression. The leg is telling you it needs more to be able to impact that underlying venous hypertension. So, have you got it right? Just look at your patients. If you've got legs that's looking like this, you haven't got it right. We need to be thinking about what are the outcomes that we're looking for. We're looking for elimination of edema, but across the whole of a limb in a graduated way. We need to be thinking if you've still got that high levels of exudate and that really inflammatory reaction of the skin, you haven't got that compression right. Is the patient wearing it? Does it stay up? Is it looking as good as it does when you put it on, when you take it off? If it does, you've got it right. And if the patient is wearing their compression, if they have embraced the compression because they love the sensation, they love the outcome, they love the way that their limb feels supported, because their signs and symptoms of venous hypertension have been resolved by this compression therapy, you've got it spot on right. So EWMA's recommendations is that we should be using at least mild compression in any patient with a lower limb wound that hasn't got any of those red flags. We should be using that strong compression of 40 to 60 on most patients with a leg ulcer. However, evidence suggests that strong compression may have additional benefits such as increasing times to healing, reducing exudate, and improving patients' quality of life. So if any of you are out there and you feel like that you are a bit, all of this is a bit complex and you don't know really what you're doing with this, please escalate. If in doubt of any of this, if you've seen any of this that we've seen, the one thing that we'd like you to take home is escalate. Escalation is not a marker of poor care. If anything, it's the complete opposite. Escalation is a mark of really good care. Patients need the accurate diagnosis, evidence-based treatment outcomes to optimise their own outcomes. Delays in this will increase patient risk and it's a direct patient harm. Escalate if you're uncertain about what factors that contraindicates the use of compression. Most patients are suitable for compression. Escalate if that wound has got some atypical symptoms. For example, if it's really unusual appearance or there's a terrible pain associated with it. And escalate if that wound's showing no signs of improvement of 40% at about 4 weeks. Escalation is the marker of a safe practitioner who delivers high quality evidence-based care. So I'd like to now hand over to Kate Williams, who's going to talk to you really about making sense of compression products. We'll keep asking questions. We'll be here at the end for a live panel chat. Thank you. Kate, over to you.
Thanks, Leanne. I'll just share my screen now in a sec. Okay, so now you've heard Leanne, you've heard Sarah, and so hopefully at this stage you're really starting to understand why compression is so important. What I need to try and do in 10 minutes is help you understand the products which will help you achieve the right dose for your patient. So this first slide just gives you some kind of an indication as to the amount of choice that can be out there for some clinicians, particularly in the UK. And what I want to try and do is simplify it so that you're not completely blown away and so confused about the range and colours and sizes and different types. So I want to try and simplify it so you go away from this confident in making a change for your patients. So first poll, quick question for you all. Which compression system do you use the most often? So you can answer more than one if Niles can put the poll up. Thank you, Niles. So which compression do you use the most often? Elastic or long stretch bandages, sometimes referred to as 4-layer or 3-layer. I'm going to explain the layers thing in a second. Inelastic or short stretch bandages, compression hosiery, compression wraps, or do you not use compression? So I'll give you all a few minutes to answer that. Be interesting what the answer is. So many answers, Niles?
Yes, we're just hitting 200 answers now. Still.
Brilliant.
Yeah. And good.
Oh, interesting. So the majority, 38%, use inelastic or short stretch bandages, followed by hosiery after that, 29% long stretch bandages, 22% wraps, and 20% of you don't use compression at all. So hopefully after that, this will change and you'll go out and educate yourselves. Thank you, Niles. So I'm going to go through each of those in turn just so you have some kind of an understanding of when you'd use them on specific patients. So we're going to start with compression bandages. So these are most suitable for patients who have high levels of exudate, patients who have edematous limbs and limbs which need reshaping. So compression bandages will fit on any shaped limb. The more practical tips really for compression bandages is that you need to access the training and support until you become competent. So for those of you who aren't applying compression bandages at present, it's fabulous that you are here and you're clearly going to go on and change that, but access the right training and support, get your skills and competence up, and then start applying the compression bandaging. But you need to consider the rest of the workforce, and we need to consider who else can do this when you're not there. Is it the patient or family members that might be changing the compression? So just thinking about, it's probably not you that will be doing it the whole time. So when you're thinking about what compression bandages to use, do consider the rest of the workforce. Wherever you work, particularly if it's in the UK, there will be brands of bandages which are on your local formulary. So I would suggest that you learn those really well. You can use the local companies to support with training and education, and they will support you to learn more and more about those products. It's important that you really understand the products that are available to you and get really good at using them and confident and competent. So compression bandages, like Leanne has just said, when you use compression well, when compression bandages well, when you use it at the right dose, images such as that on the right will be a thing of the past, because that is an undercompressed limb, as Leanne has just explained. And with the right compression bandaging, that would be progressing to healing. So you, like Leanne said, if you know you've got the dose right, the wound and the leg will improve. So advantages and disadvantages of bandages. So advantages, there can be a rapid reduction of edema, particularly with inelastic bandages, so short stretch bandages. Like Leanne just said, that is the first sign that you've got your compression right and you've got your dose right. Disadvantages, like I've mentioned, it needs a skilled practitioner who can apply the bandages, somebody who is confident and competent. As I've mentioned already, the advantages of bandages, that it can fit over any limb shape, over larger dressings, but sometimes consistency is so important in bandaging. If there's a lot of different staff members, it can be difficult to get consistency if everybody hasn't got the same level of competence. So that can be a disadvantage of bandaging, which other forms of compression, wraps, hosiery, for example, that's less of an issue with those. So under the advantage of compression, it's a great way to try and introduce compression gradually for more reluctant patients. So some patients, they might have painful venous leg ulcers, and it's very difficult sometimes for patients to understand that this bandage is actually going to help them. It will help their pain, it will improve their pain. So sometimes we do need to start compression gradually, and you can do that with bandages, particularly the elastic bandages. You can gradually increase, kind of coax almost a patient into wearing compression so that they trust you, they trust the bandages, and they can feel the improvement. So you can do that with bandages. It's much easier to do that with bandages than any other type of compression. I must emphasize though that if you are thinking about working in that way with some patients who might be reluctant to have compression, it's great, but please don't drag it out over months and months and months. When I'm saying that you're slowly introducing the compression, that's at each visit. So you're introducing them gradually. Bandages are great for doing this, but please don't drag it out over months and months. When you're increasing that dose to try and get them up to the strong compression level, it needs to be done at each visit, but please don't drag it out for too long. One real advantage of compression bandages is that they can be bulky, they can be less aesthetically pleasing for patients. I understand, I appreciate we can get temporary footwear. In the UK, you can get temporary footwear on prescription, but we need to be careful with this because as Sarah and Leanne have just said, the role of the calf muscle is so important. And if we're going to prescribe temporary footwear for patients, which is very rigid, it actually impedes the calf muscle pump function. So the foot flexion is less, they walk very flat-footed. So the bulkiness we sometimes think is offset by this temporary footwear, but please be careful with that because it can affect how the patient walks and can affect the effect of the calf muscle pump. So another advantage, some elastic systems do come with guides printed on the bandages. Again, stick to the ones that are on your local formulary, but that is an advantage that some bandages can come with guides. For example, there might be a shape on the bandage that when you pull it to the correct stretch, it changes from an oval to a circle, for example. So it just gives you some indication of whether you've got the tension right, which is really helpful. But a disadvantage of bandaging would be that it is more difficult for people who wish to be involved in their own limb for self-care or shared care. That's not to say that I haven't taught patients' relatives to apply compression bandages. I have. Some of them have done an excellent job, but that's on a really specific patient-by-patient basis. It's something that has to be considered carefully. So another poll. Do you understand the difference between elastic and inelastic bandages? So this is a term that we kind of band around. It's quite important that you understand the difference really so that you can choose the correct treatment for your patients. So do you really understand the difference between elastic and inelastic? So this really comes down to, as Leanne has already mentioned, the function of the calf muscle pump. So as the patient walks and the calf muscle expands and contracts with a more rigid inelastic bandage, those pressures, so it's often called a working pressure, inside the calf muscle deep in those veins can be much higher. So when we talk about working pressure, that's what we're referring to, and then resting pressure is the pressure when that muscle is at rest. So is the result for that one, Niles? Oh, great, 70%. Brilliant. So for some of you, you'll know this, that's brilliant. Bear with me. But for those of you who don't know it, I'm just going to explain briefly the difference. So as I've mentioned already, elasticated bandages have less stiffness. Bear in mind, if you're putting 2 layers of this on, the stiffness will increase. It's inevitable. Any kind of layering will increase stiffness, increase rigidity, but elasticated bandages are less stiff. So as I've mentioned already, they can be used to introduce a lower dose of compression, and they have a lower working pressure. So because there's some give in the bandage, when the calf muscle expands and contracts, the bandage kind of gives a little bit. So they've got a lower working pressure. The inelastic bandages, however, have a much greater stiffness. It's more rigid. It's that, without doubt, the bandage type of choice for chronic edema and lymphedema. So if you think about those pictures which Leanne showed with the slimmer leg on the left as you look at the slide, and the larger, more fibrotic, harder edema on the right as you look at the slide, that limb would most certainly need the inelastic bandages. So as mentioned already, the inelastic, it creates the stiffness, much higher working pressure as the calf muscle expands and contracts. So compression wraps. Some of you mentioned in the first poll that you are using these. From an evidence point of view, the jury's still out. There is a randomised controlled trial, so Venus 6 is underway, which is looking at other forms of compression, including wraps. For those of you who aren't familiar with them, it's quite a rigid fabric which is wrapped around the patient's leg and held in place with Velcro. So the obvious advantage of that is it enables self-care. They're very easy to apply. Some patients find them, they look much better. The opposite of that is some patients think they look awful. I never know what the patient's going to say. Generally, I find younger men prefer the look of the wrap. Some elderly ladies I've tried to introduce to wraps think I'm absolutely crazy because they don't like the look of them. So it's up to the patient, it's entirely up to them. But the aesthetics of this is important to the patients because they have to wear it all the time. So think about that. So wraps, some people love the look of them, some people don't. A real great advantage, again, thinking back to that bigger leg that I was just talking about that Leanne showed, the much larger heeled leg, but larger leg which need a much higher dose of compression and more rigidity. These wraps can be really useful to use over compression hosiery for healed lens that need that higher dose of compression to maintain their skin integrity, to keep healed. Okay, so that's just something you can use for patients who need stronger compression to remain healed. An advantage is it's another option for patients. We need to give patients choice. They need to be able to choose the kind of compression which they are comfortable with, they like it, they can live with it. So although there are differing levels of evidence for each of these compression types, it's important that you know about them all. And it's important that you can offer them to your patients, because the one that the patient loves is the one that they will wear. And that's what we need. We need them in compression. Another advantage is compression wraps. There's very little training required. They're very straightforward to put on. It can really, very easy for family, patients themselves, carers to apply compression wraps. One disadvantage though, the patient really needs to be engaged and motivated with this. I've had patients who like the look of them, they've tried them, we've prescribed it, felt they were comfortable, everyone was pleased, but they weren't really engaged enough. These wraps need tightening throughout the day, they can slacken off, they need putting on at the correct tension in the first place. And for some patients who aren't entirely engaged, you find sometimes that they just almost rest them on the leg and they don't use them properly. So it's really, really important that the patients that you choose to put in compression wraps are engaged, they're motivated, they're physically able to reach down to their leg to adjust the wraps, and that they understand that the tightness you apply it with is the tightness that they need to apply it with. So I've fallen foul of that myself a few times, and we've had to put patients back into bandages because their legs have started swelling because the patient wasn't engaged enough with the compression wrap. compression hosiery. So I'm going to really briefly touch on this because we're quite short on time. I have got some additional reading to signpost you to, which is an excellent document. But what I want you to take note of from this slide is the doses. So you can see with compression hosiery, there is different standards which give you different doses of compression. So within the UK, just as an example, we would usually use either British standard or RAL standard hosiery. So the way to start thinking about choosing compression for your patient, as Leanne has said already, just think all about edema. So we've mentioned already the more rigid inelastic bandages is better for edematous patients. When you're thinking about compression hosiery, the stronger fabrics are better for edematous patients. So for patients with edema, I would always go for the RAL standard compression hosiery. Again, there's different fabrics. So British standard hosiery tends to be quite thin and quite sheer by comparison to the others, which is great for some patients, for patients who might just have that really soft edema that Leanne was describing. That might be fine for British standard hosiery. People with mild varicosities, some mild aching at the end of the day, British standard hosiery could be perfect for them. But you need to know, does the fabric fit your patient? If it's a big leg, quite a firm fibrotic leg, you need the firmer fabric from the RAL standard. Okay, so I'm not going to go through the doses in detail, but one thing I really want to highlight is the hosiery kits. So hosiery kits give 40 millimeters of mercury within that kit. So the hosiery kit is actually 2 layers of compression hosiery, one open toe, and then beneath that there's a closed toe. Different companies make them. The level of compression, either the top layer or the bottom layer, can vary depending on the manufacturer. But what you get is a kit. So you might see it called a hosiery kit, or you might see it called a leg ulcer kit. But within that, that gives 40 millimeters of mercury itself. Okay, so that comes in with the compression hosiery, but that is full 40 millimeter mercury compression. Okay. If you'll note here that the 14 to 17, 18 to 24, we know that we are thinking about 40 millimeters of mercury. So for example, you've got the hosiery kits if you want to use strong compression, but thinking about those patients who are healed, who ideally would be in at least class 2 compression hosiery to prevent recurrence. However, some patients find them difficult to get on. You can get, as part of the leg ulcer hosiery kits, some of the liners are as low as 10 millimeters of mercury. So an excellent tip really, which I found really useful for my patients, or some of them, is to layer compression hosiery to help the patients get it on and off. Again, it's all about the patient. They need to be able to use the compression and like it. So if you're prescribing compression hosiery for patients, please consider layering to achieve the dose. So you might use 2 10 millimeter of mercury liners to achieve 20. So this is a really useful table to try and keep to hand. The document I'm going to recommend it shortly has got all this information in it, but don't forget layering. That was one of my key messages. A little note, if you are going to layer compression hosiery, please make sure that one of the layers is open toe. We don't want too much squashing around the toes.
Kate, so you're going to have to do a half a sentence for each slide because we've got so many questions.
Alison, that's fine. So hosiery kits that I've mentioned, there's an RCT there, which is fabulous. You can go back and look that up. Key thing from this, as soon as the limb shape is optimized and the exudate is reduced, get your patients into hosiery kits. They associate compression hosiery with healing rather than bandages with healing. And it is much easier to sell, so to speak, lifelong compression hosiery if the patient associates it with healing. The most important thing is please include the patient. It's their leg, it's their hosiery. I'll let you read these points here, but then make sure that when you first prescribe a patient hosiery or compression, let them know it's not the only choice. Just say, we're going to try this first. If you don't like it, if it doesn't suit you, it's no big deal. We've got lots of other options to try. Please don't rule it out. So this is the recommended reading, which you can access later. And then just in summary, that's the slide there. So this table is from that document, but the main thing is get the dose right, use EWMA. EWMA will help you narrow down the options for compression, learn about the compression on your local formulary or whatever you're going to get access to, and always involve the patient to get the dose right.
Brilliant.
Thank you, Alison.
Thank you very much, Kate. If you can stop sharing.
Yeah.
That would be lovely. Thank you. We've had so many questions here. So I'm just going to share my screen very quickly, and I'm going to keep talking whilst the poll comes up from Niles. And this is looking at the work that we've just presented. Will it make any difference? Has it made you think? Pop it in the chat as well, and let us know what you think. So whilst we're just just completing that, this was a webinar, just to be clear, because we've had some amazing questions in the chat and the Q&A, and you just need to be clear about the fact that this was really aimed at a generalist audience, and it's so lovely to have everyone keen, but the depth of level about compression therapy was at that level. So we're not able to attend to all the questions that that were asked. So Niles, can you just pop the answers up there just to see what you're having? Yes, absolutely, that's good, and I'm glad it's making you think. And it's interesting for the few people there that say that protocols will prevent it. We've all worked with protocols, and this is where you need to challenge the protocols, because there is enough evidence now and there's enough of a national push to go, we need to do this differently. So how can you do this differently? One is about the resources, and so if you do come back to this, you'll find it on the websites for EWMA. I put in the link earlier, or if I didn't, Niles, can you just put in the link to the EWMA compression therapy, where you can share the video with your colleagues. So there's educational materials there, and what we haven't shown you is some of the graphics and flyers that's available. So look at that, we've used them in the some of this material. Go to the Legs Matter campaign, legsmatter.org. and look at the information. And just to say, for patients, family and friends, there are downloadable PDFs that have been developed. And the Legs Matter Coalition has patients on the panel, which is a powerful tool for us all to learn from. So we've had a lot of questions. So I'm going to direct a few. We've answered them as we've gone along, but we're like typing fast, folks, I tell you. Right, there was a question about waddingitis, loved it, waddingitis. So Sarah, what would you like to say about waddingitis? How would you direct wadding to be used correctly to reduce risk, but not to go mad with wadding that creates footwear problems?
I love it, waddingitis. I don't think I've ever heard that expression. It's been the bane of my life, I think, seeing patients where sometimes 3 or 4 rolls of padding that's been put on. Basically think about why you need it, which is really for protecting bony prominences from maybe the pressure from the bandage. So less is more, because the more you put on, you increase the risk of slippage, and also you are then reducing the impact of that bandage that you're applying over the top. If I have to put it toe to knee, I just put a thin layer on. If you have got a very bony prominence, say on the tibial plateau, you can put a strip along the tibial plateau. You haven't got to wrap it around the leg, and maybe a wrap around the malleoli if they're bony as well. But more wool will result in less compression and slippage, so just use it carefully. And you sometimes don't even have to put it around the foot, you can just put it around the malleoli, and that would help then with getting footwear on as well. That's my opinion.
I would agree with that. I'm going to move on to a dosage question. Leanne, role of reduction in inflammation. Tell us more about that, because that's something that, we're trying to show people that a bandage doesn't need just to go on. It does something powerful, and it creates an impact, and it's a therapy. Tell us more about why it reduces inflammation.
Well, I think Sarah's really brought that home in terms of how many different aspects compression therapy works on. It is multifaceted, the way that it actually is an anti-inflammatory, because it directly impacts on the number of cytokines that's happening on that wound bed. It directly impacts on the level of exudate, and it directly impacts on the venous hypertension, the reason why it came in the first place. So that compression therapy works on all of that, hence why we're trying to talk about it as a therapy, to actually get somebody to link the fact that, you know, if you've got cancer, you get chemotherapy. If you've got venous disease, you should get compression therapy. And we're trying to make a link really more between that underlying disease. And think of a leg ulcer like a weed. That's where we need to be targeting. But just like chemotherapy, we dose the chemotherapy to the individualized patient. We need to be dosing the compression to the individualized patient, so we get that specific anti-inflammatory response in that individual. We are not all the same. We're all very, very different indeed.
Yes, there's a push for standardization that gives us an additional problem. What do we say to people, Kate, where they say our protocols can't allow us to do this? In the UK, I'm talking again to the UK audience.
I'd have to question what kind of protocols would advise against compression, and really it's, as clinicians, we are the patient's advocates. We know that compression therapy is an essential treatment for venous disease. If the patients haven't got access to that, we should challenge it and we should question it. We wouldn't accept if patients weren't able to access treatment for other conditions.
Yeah.
So it's an essential treatment for venous disease, and we've got to shout up because we are the patient's advocates.
I think it's an interesting one about it being an optional extra. It's like, I don't have time. And actually, there's a lot of, evidence to show that if you put the time in, unfortunately, like anything, you put the time in early, you reap the rewards. Not only the patient, but you and your team does as well. So we've been asked as well about wraps. Wraps have come up a lot in the chat, actually. And you would use wraps, but I'm always conscious that wraps are something that need to be tweaked. You talked about that, Kate, about the need for putting it on and retweaking daily. But some people have it put on at the leg ulcer clinic on Monday, and they'll have it be reevaluated on the following Monday. And the question about efficacy and consistent dose doesn't seem to come into it. No. Has anyone got any thoughts on that one?
I think that the thing we have to bring to the forefront with compression wraps is that there is no level 1 evidence that this moment in time that compression wraps heal a venous leg ulcer as good as multi-component bandage or a compression hosiery kit. I think that wherever possible, we should be using true evidence-based solutions for our patients. Multi-component bandage, hosiery kits providing at least 40 milligrams of mercury. I think that we should only really be using compression wrap systems if a patient wants to do that self-supported management and cannot do it by one of these two options. We really need to be thinking, many of you will be aware in the UK, there's a massive randomised control trial called Venus 6 that's going on. It's a 3-layer randomised control trial. That will give us the answer of whether compression wrap systems are as efficacy in terms of healing a patient leg ulcer. Because like you, Alison, I have got worries that the fiddle factor is going to impact actually on the dose of compression and therefore the healing.
I'm conscious we've got 3 minutes left, and I've just seen a comment from Jean Mooney. You did not mention the venous foot pump, which is, for us that are really into mobility and biomechanics. Again, this seminar was for really focusing on the power of compression, and that we need to make sure patients access it. However, biomechanics is really important. Joanne, what do you want to say to someone that goes, we haven't mentioned the role of the calf muscle pump?
Yeah, thank you. So it is really important, the role of the calf muscle pump. I mean, we did mention, I can't think it might have been Leanne or Sarah mentioned the calf muscle and the importance of that ankle movement and not inhibiting it at all, especially with footwear. I think Kate brought in the footwear side and the extra wadding and all of that, so not limiting that. So it is really important. We always include the foot, you know, because actually otherwise you would just sort of herniate everything south with dependent edema. So it's important to kind of include the foot as well in all of the compression. So, I mean, Jean actually is part of our vascular advisory specialist group. So I'm sure that that's a topic close to her heart, actually. So I hope I've done that justice for you, Jean.
Brilliant. So to end on, we've got the numbers have gone down now, so I think we'll curtail the conversation. But I really wanted to thank each one of you that's put the effort in to do this on behalf of the Legs Matter Coalition and to promote the EWMA compression project. So thank you very much, Kate, Sarah, Leanne and Joanne, and thank you, Niles, for your help in securing this webinar. So it will be available via the recording via EWMA and also the Legs Matter Coalition and so on. So thank you very, very much for a fantastic debate. Look for resources to learn more about compression. Thank you very much.